Hey everybody, this is Kevin with Garrison Dental Solutions. I want to say thank you so much for joining us here this evening. You're part of what is going to be probably the largest crowd we've had for a webinar. We've got a fairly decent proportion of the dentists in North America who are going to be joining us here this evening. We're expecting a great presentation from a very talented clinician. Dr. Carla Cohn is with us here this evening. Last year, I was lucky enough to be up in Winnipeg at her office, and I got to see her in her native environment and get to watch her perform her magic on several young people, and it was really great to watch and really enjoyed that. So without any further ado, I want to go ahead and introduce Dr. Cohn, and she's going to take it away.
Well, thank you very much. Thank you for having me, and it's very exciting to have all of you here with me tonight. It is nothing short of amazing how we can reach out to so many different people around the world to come in and see this webinar. And you know, I thank you to Garrison and particularly to Kevin. This webinar idea was created when he came down to visit me in Winnipeg last summer. So this was all pre-COVID-19, and this is really my everyday bread and butter dentistry that I do in my practice. So it's a pleasure to be able to share it all with you. And so tonight's webinar, we're going to talk about primary dentition, intracoronal restorative treatment, the techniques, tips, and tricks of the trade. And this is pediatric dentistry for and from the general practitioner. So I am a general practitioner. I graduated from University of Manitoba back in 1991. And after that, I spent a year doing an internship at Children's Hospital, and haven't looked back since. I have devoted my entire career to seeing children in my practice. It's what I truly love to do. And about 10 or 12 years ago, I started speaking about what I do. So went around and gave some lectures and giving some teaching tips to all of the general dentists out there, because truly the secret is that seeing kids is really the best thing that one can do. And it is the easiest, and it is just super fun. So I hope that you will think the same before, during, after tonight's webinar. So just want to point a few things out for you on this front page. This is my personal email address at the bottom left. I have a little bit of apprehension giving that out there to 1,200 people, but I just did anyway. So drcohn@shaw.ca. Feel free to shoot me an email afterwards if you have something nice to say. I'd love to hear from you, but if you don't, then really don't bother. Underneath that's my website, drcarlacohn.com. So you can go to that for some resources. I do have some articles that I've written. It's all clinical articles. I'm a clinical dentist. I spend most of my time in my private practice, at least I did pre-COVID-19, and do a few days a week in private practice, and then a day a week or two a week in the operating room where I see kids under general anesthetic. Catapulteducation.com is the speakers bureau that I belong to, and we're a group of clinicians who go out and do exactly what I'm doing, and part of that is also trialing some new products and new materials, new techniques, new technologies. Underneath that, aapd.org, and that's the American Academy of Pediatric Dentistry, and that is a great resource for a lot of good child dental related questions, and feel free to go to that. You don't have to be a member of aapd.org to access most of their resources, but if you want to have more of their resources like journals, then you do need to become a member. And underneath that is my Instagram account. That's @KidsDentistCarla. So I'd love to have you all follow me. I post a ton of stuff clinically and anything that's relevant to what's going on or what's happening in my practice, and also a lot about my two puppy dog doodles. So feel free to go there and follow me, because I'd love to have you. A little bit of a concern tonight that we might break the internet. So if we do, we have a backup plan. If for some reason your screen goes blank, Kevin's going to hop on and I am going to switch devices so that we can continue talking. So this is a picture of my speakers bureau. Friends and family, we can call them. And if you're looking for some great speakers, it's a great bunch of people. You just go to that Catapult Education website and you can find speakers about pretty much anything in dentistry that you would want to know about. My disclosure is that I do work with many different companies, and I trial their products and I will speak about their products, and my rule is that if I like it, I use it, and if I use it, I talk about it. So anything that you're going to see in tonight's webinar are all products that I do use in practice, and I'm going to speak about several of them tonight. But our highlight tonight is for Garrison and Garrison matrix systems, and we're going to talk about using them. You're going to see the Garrison matrix systems in my clinical photos tonight, and I have a lot of videography as well that I am going to share with you. So this is one of our housekeeping slides that I need to put up for you. I'm not sure whether you know this or not, but you will get an email evaluation and quiz shortly after the conclusion of the session, and both are electronic and need to be completed in full in order for you to receive your 1 hour of continuing education lecture credit. There's a deadline to complete by the end of April. And then Garrison Dental Solutions will email you your course attendance verification after your quiz has been submitted. If you don't receive it, make sure to check that spam folder and see it hasn't gone to junk. If you're an AGD member, include your AGD member ID number in the space provided, and they will submit your participation confirmation to the AGD for you. And you will need your course verification code provided at the end of the webinar, so stay logged on all the way through. So kids come into our practice, and sometimes things can get a little bit hairy. Sometimes things are just a little bit out of control. And sometimes kids can make you feel a little bit anxious. Most of the time they bring joy into our lives, but sometimes they can strike fear into our hearts. And we need to know how to manage kids and how to manage them well, because in the end, kids' teeth matter, and it is very important to be able to be treating our children well. And why is it important as a general dentist to know what to do with the kids in your practice? These are the statistics, more or less, of the general dentists in the United States. There's about 155,000 and change. And then there's pediatric dentist population, just a little bit over 7,000. And so what that amounts to is about 4.7% of dental professionals are pediatric dentists, which means that most of the children in your practice, or most of the children in the community, are going to show up in your practice. And so we need to know how to do it well, and we need to know how to do it well the first time. It's been said that if all you have is a hammer, everything is going to look like a nail. So if the only restoration that you know how to do is a composite, every filling you're going to do in your practice is going to be a composite restoration. If the only full coverage that you know how to do is a stainless steel crown, that's the only full coverage that your kids are going to get. And really, we have a toolbox out there that's available to us. So many different things in our market that we can use to help our kids, materials, technology, tools, and it's up to us to get out there and to be able to know what to use and to know how to use it. And so I know that a lot of us are taking this opportunity with COVID and being off of practices to learn, and I am as well, and I appreciate that we are all doing our part to learn and make things better for our kids in our practice. So I love this, is back from 1920. This is actually the volume 1, work on operative dentistry. And so this is talking from G.V. Black back in 1920 about doing some operative dentistry. And when he speaks about seeing kids, he says, it should be remembered always that success in the treatment of these teeth depends on the same care as the treatment of the teeth of the adult. And the fact that they're to serve only for a short time is fully counterbalanced by the other fact that the tendency to caries is much greater in the child. So that because of any little neglect in operating, decay will recur more rapidly and the fillings will be more quickly undermined and destroyed. And for this reason, careful attention should be given to every detail of the operations upon them. It was true 100 years ago, and it's absolutely true now, particularly when we are working with composite resin, which is a very technique-sensitive material. We must be very careful to have great attention to detail. Composite resin recommendations, according to the American Academy of Pediatric Dentistry guidelines, are for to be used in primary molars. There's strong evidence that composite resins are successful when used in class 1 restorations. For class 2 lesions in primary teeth, there is only one evidence showing success of composite resin restorations for 2 years, so not very high. In permanent molars, there's strong evidence from meta-analyses that composite resins can be used successfully for class 1 and 2 restorations. And evidence from meta-analysis shows enamel and dentin bonding agents decrease marginal stainings and detectable margins for different types of composites. When we're treating kids, we need to keep things short and sweet. We want our procedures to be concise. We want to be able to be efficient. We want to work quickly, and we want to work effectively. And as I alluded to with the toolbox, we have so many to choose from when we're looking at materials, so many to choose from when we're looking at armamentarium. How do you decide? Well, I haven't quite decided. I use a bunch of different products and a bunch of different materials, and you'll see just that. But when it comes to matrix systems, the superior matrix system out there is the Garrison matrix system. And this is the latest of the Garrison matrix systems. And this is on 2 primary molars, the first and second primary molar. And as you can see, we're isolated with rubber dam, and we have the matrix system in place. So I'm going to show you exactly how to get these matrix systems in place and how to do them effectively so that we have great long-lasting restorations. I'm going to do that with a bunch of clinical photos and a bunch of clinical scenarios. So these are all going to be my kids that I see in my practice. These are all photographs that are taken by my dental assistant, and all of the videography is taken by my dental assistant as well. There's going to be a mixture of photographs that are taken both in the operating room and at the clinic, but most of the videography is done in the operating room for the simple reason that in the operating room, our kids are just very nice and still. I'm going to talk about doing restorations with Admira Fusion Extra from Voco. This is a 1-year post-operative of an Admira Fusion, adjacent to a zirconia crown from New Smile. That's going to be one of the first cases that we're going to look at. We're going to look at using Omnichroma from Tokuyama. This is a 6-month post-operative of a primary molar with the Omnichroma from Tokuyama. This is Grandioso from Voco, and this is a 2-year post-operative of an MODO. I'm going to show you how to do a back-to-back at the same time, MODO. And these are the Beautyfill composites from Shofu, a whole family of Beautyfill composites they're called. And then I'm also going to show you Luna, which is a composite from SDI. And finally, a composite resin called Evanes from Clinical Research Dental in the States. I believe that's called Clinician's Choice. So I'm focusing on composite resins, but glass ionomer cements can be used effectively as well in interproximal restorations in MODOs. And there's evidence showing that glass ionomer cements and composite resin present similar clinical performances except for secondary lesions, so a recurrent decay or a residual decay. And in that case, glass ionomer cements present superior performance, especially resin-modified glass ionomer cements with rubber dam isolation. I'm going to show you 2 different types of placement techniques, and these are the 2 types of placement techniques that I use most commonly in my practice. The first is a modified snowplow technique, and the second is a base layer technique. And why is it, of course, important to do effective work? And why is it important to not have failures? Almost half of all restorations placed in the United States are class 2 restorations, and 70% of all restorations placed are composite resins. So it's a very common material to be using in our offices. And having said that, it's also a very technique sensitive material. Have you got any idea how much redoing a failed class 2 restoration is going to cost you? $50, $100, $200, or $300? The answer is it's going to cost you $300 to redo a failed class 2 restoration. So it's a high cost, never mind the aggravation of having to do it. And on a child, we don't want to have to do things a second time or a third time. I'm going to also share with you several tips and tricks for success. So smattered throughout the presentation, I'm going to share about 7 or 8 different tips or tricks to succeed beyond just placing good, solid matrix systems and restorations. And the very first, very most important thing that we have to do is we always must isolate. So we always need to isolate when we're doing composite resins. And rubber dam is high on my list of favorites. I also do use isolation systems, but to do restorative dentistry on a child, we must have airway protection, we must have a dry field, we must have proper isolation. And also, we must always manage the pain control. We never want to create a situation in which a child is having pain. And so the rule that I go by is, if it's going to cause discomfort to that child, we must anesthetize that child. And one of the other most important things for success is to never underestimate the size of the lesion. Never try and put a composite resin restoration into a lesion that is just too large to hold a composite resin restoration. There's several things that we need to remember when we're looking at primary teeth and cavity preparation. So primary molars, when we're looking at their anatomy, we want to look at the enamel. We know that the enamel of primary molars is much thinner than the enamel of permanent molars. And so we have that much less ability to etch and to bond. As well, many kids will brux. And so on the occlusal surface, if you're relying only upon etch and bond and a child bruxes away the entire occlusal surface, your entire retention is just gone if you don't have any mechanical retention in there. So keep in mind that that enamel is thinner. Keep in mind that the pulps on the primary dentition are much larger in relation to the crown than they are on a permanent molar. And so you must be more conservative in your preparations for your MOs and your DOs, because it's not far before you might invade that pulp. That dentin enamel junction is very close to that pulp horn, particularly on a first primary molar. So this is a preoperative photo just to show you a bit about design preparation. And we're going to cut an MO and a DO here. So this is, standard garden variety cavities. And we've got mesials and we've got distals. We need to cut an MO and DO to get a composite restoration in there. And the key is we must be conservative. So you absolutely must be conservative. The more material, tooth material that you can leave on the buccal and the palatal aspect of this tooth, the stronger the restoration is going to be. Now, that's not because we don't have very strong composite restoration materials, but it's because the strength of the tooth itself is not very high on those lingual and those palatal and those buccal walls. You can see on this tooth, we've already got some wear facets, and this child is under the age of 5. So over time, they're going to continue to wear, and if we have very thin buccal or palatal walls, then we're going to have fracture. The other thing that we need to do is we need to be able to isolate with a matrix system. So I'm going to talk about or show you clinical photos of the Compositite 3D XR, which is an earlier generation of matrix systems from Garrison Dental Solutions, and this is what the kit looks like. I'm also going to talk about their newer compositite 3D fusion, and this is the kit of the compositite 3D fusion. So if you look up in the your upper left of your screen, you've got your forceps to put your rings on, and you've got a little instrument here also to help to remove the bands after the procedure is done. We've got 3 different size bands here. We're going from smallest to the largest, and I'll show you some photos of our smallest and also our medium one. When we're talking about primary teeth, unless they're very, very short primary teeth, you can pretty much interchangeably use your blue and your orange ring. Your green ring, though, is going to be saved for permanent teeth. And then as far as matrix beans go, or matrix bands go, then these are one of the styles of matrix beans, I'll call them. And this one has a little tab on the top. So this is good if I'm doing a single MO or DO. But if I'm doing back-to-back restorations, I prefer this style of the band, because this style, I don't have the little tab and I fill them back to back at the same time, then I can see very well what it is that I'm doing. You're also going to see throughout my presentation different wedges. So these are the Garrison Fusion wedges, and they look like they have little feathers on them. So these are placed interproximally like so. They're very comfortable because they're soft and they adapt, so it's a rubberized material. Sometimes we don't always have, if we're doing a maxillary, we don't always have palatal anesthesia, so to have a soft wedge is very important, and they don't back out. Now you can use any of these interchangeably with the matrix systems, regardless of whether you're doing with the tab on it or without. And these are the wedge wands. You'll see these in my presentation as well. These are easy to put in because they have a little stick attached to them, and you don't need to have an instrument to place them. So you just put them interproximally, and some of the wedge wands are translucent and allow cure through. So the Garrison systems, the Garrison dental solutions, have evolved over time from 1997 when they were introduced until now. And you may have some of these in your office that look familiar from 1997, all the way up to these ones that were introduced in 2017, the compositite 3D fusion. So when we're putting these in, and this is a typodont, obviously, that I'm showing you. So we're putting them in place. We put our little matrix beans in. And then what we should do is we should peel those matrix beans close to the tooth, hold them close to the tooth, and then place our wedge. Once the wedge is in place, we follow with the matrix rings. Now, I'm not so concerned about interproximal contacts. They're primary teeth. The movement of primary teeth is such that when we have eruption of 6-year molars and so on, the contacts change. What I'm more concerned about is isolation at the base of that restoration, that gingival box, because that's where we're going to have problems with seepage of crevicular fluid, possible contamination, blood and saliva, even if we are isolated with rubber dam. So this study tells us 97% of clinicians say achieving proper isolation of a class 2 cavity is difficult in at least 1 out of 10 cases, and that floor of the proximal box of a class 2 is most susceptible to blood and saliva contamination. So the first technique I'm going to show you is a modified snowplow technique. And just as an aside, it's April the 14th today, and it was snowing in Winnipeg this morning. A modified snowplow technique goes as follows. We use either a selective etch and bond, and then we do selective etch and then bond, and then we light cure, place a thin layer of flowable composite, but we're not curing that. That thin layer of flowable composite is going to act as caulking. And then we place composite resin in a single increment, so as a bulk fill, and we light cure that together. Then we place flowable composite to seal the entire occlusal surface and light cure again. This is adapted from the injection molded technique from Dr. David Clark. So this is our example doing the modified snowplow technique. I have my Garrison matrix system in place, and as I said, so now this is one that I'm using a tab because I'm just doing an MO here. This first primary molar will in fact have a crown on it. Our selective etch technique involves selective etch only of the enamel. So we're using the total etch on the enamel when we talk about selective etch, but self-etch on the dentin when we do self-etch. If we use a nice high viscosity etch, like this example from Bisco, it will allow us control of placement of that etchant. And the results of a selective etch technique are that it will increase the bonding effectiveness for one-step self-etch systems, regardless of whether we have a permanent or a primary tooth. Now, of course, we want to use a good bonding system, for example, all bond universal from Bisco, and that universality means that we have technique flexibility and we can use it as a self-etch, a total etch, or a selective etch. So make sure that we've got the adhesive onto the brush and we cover all of the surfaces that we need to bond. And then we apply a little bit of air to get the solvent out of the way and to thin the adhesive. And then we're going to light cure. The next step in our modified snowplow is placement of a small layer of flowable composite. So think about it as about a 10% incremental fill of that flowable, and this is going to act like caulking. In this case, I'm using the Admira Fusion Extra. This is an all ceramic based direct restorative material composed of silicon oxide for both filler and matrix. It handles exactly like a composite resin, but it doesn't have any of the resin components to it. It has instead the silicon oxide. We must bond it, and we can do either bulk fill or regular fill. So this, I'm using a bulk fill. I'm using the Admira Fusion Extra. We place it in completely, and then we are going to shape it. So I shape it with a ball, and then make sure I have my embrasures. And this is when it comes in to be able to have the proper height of your matrix system. If you have the proper height of your matrix band, then we are going to be able to finish it without having any difficulty. At this point, after it's shaped, we light cure again. Then I place my flowable as sealant over the top, light cure once again, and then we have a finished restoration. This is the case 1 year follow-up of the Admira Fusion Extra and our zirconia crown from New Smile. So tips and tricks for success is the order of operation and avoiding contamination. Had I gone back and had I done my crown first and then my MO second, I would have a bloody field and I'd have a lot of difficulty getting any type of matrix in there. So I do my composite first, my technique sensitive hydrophobic composite first, and then the crown second. So order of operations is very important. A second case using Omnichroma. This is our preoperative case, and we have our orange matrix ring in this case, again with the tab. And Omnichroma is a material that will blend in with any shade of tooth. It's a unique material. We have our selective etch again, and we have our adhesive. Now, I want to point out in this photo that we have the adhesive going all the way down to the bottom of the box. If you can't get your brush down there, you can't get any adhesive down there. So as I said, Omnichroma is a material that will match any shade. It's a great material to use in your practice. Placement of the Omnichroma in bulk, and this is our immediate post-shaping, immediate post-curing. So this is a little video I have to show you of Grandioso. It's about a 2 or 3 minute video. So let me play it, and hopefully we, as I said, don't break the internet. And here you go. So I'm cutting with a 556 carbide burr. I find that that's a very fast way to cut, and it also has the ability to be able to put in some mechanical retention with just a slight angulation of my hand. So lots of water, and this is now a tapered Fisher burr, and I'm just going in to do a little final touching up on that preparation. Big round burr to take out decay. And we can do some selective caries removal so long as we have enough sound margin and enough ability to seal that off. Putting in our matrix band here. Make sure when you put it in, you put the tab back. And now I'm putting in one of my wedges. I keep my thumb on top of that tab in order to not have it move. And the same thing when I'm putting that matrix ring on. Now our acid etch, so our phosphoric acid etch, and we're going to do a selective etch technique. At least that is the hope if I'm not going to be too messy with my etch. We're going to wash it and dry. And we're followed by some adhesive. Make sure you've got adhesive on every surface that you need to be bonding to. A little bit of air onto there. And then a light cure. And in our snowplow, the Grandioso Flow, as the base of the restoration, about a 10% fill. If you look into my mirror, you can see the Grandioso packable going in. Make sure that there are no voids. We want to avoid the void. You should be able to see, once we're pushing this into place, some of the flowable extruding through to the occlusal of the tooth so that we have a good sealed tooth. That's the purpose of the modified snowplow technique, is to use that little bit of flowable to act as caulking. And let me point out, I'll mention this again later, these instruments that I'm using are called dark diamonds. They're from LM. If you're in Canada, those are distributed by Bisco as well. And also a point to mention as well, the Garrison Matrix systems in Canada are also distributed by Bisco. Do as much of the shaping you can at this point, because we want to have pretty close to our final shape, our final anatomy at this point before we put the sealant flowable top coat on, whatever you want to call it. Less finishing at the end of the procedure is better. The less time that I can put the handpiece in a child's mouth, the better. A little bit of flash here, but it just clicks right off with our instrument. And that should be a good functional restoration for the rest of that child's life with that tooth in their mouth. So the Grandiosos are great materials. They're very highly filled, 89% fill, which means that they have a very low shrinkage rate and a good longevity. So tips and tricks again, proper wedge placement. Not quite sure what happened in this radiograph here, why this is such an awful looking restoration. Was my wedge placed too high? Possibly. Did I not get down far enough? Possibly. Here's another possibility. Perhaps my light cure wasn't correct. Perhaps I didn't have the light in a proper angulation, or perhaps my light wasn't working well. This is a very interesting and useful device from Blue Light Analytics that will help you to test your lights and also tell you how long you need to place that light cure of every particular material that there is. I'm going to show you another videography procedure using Beautifil products from Shofu. Beautyfill are unique in that they have gyomers, which are surface pre-reacted glass, which have a bunch of ions in it that resist acid, resist the formation of plaque, help to remineralize, lots of good materials. And so let me play you this video. This video is going to show you a back-to-back. So this is already prepared, so we don't need to, you don't need to sit through the preparation again. So when I do back-to-back, remember we need to use those matrix beans that don't have the tab. And that is because I won't be able to see beyond the tab in order to see to the base of my box. So you can see here, I'm going to pull that matrix band back with my cotton pliers so that I can get my matrix ring on. Keep your finger on there. This is the wedge wand that I was talking about with the little stick. Now you can leave that stick in place, or we can twist the stick off. If I've got my, let me just say here too, at this point when we're placing the ring on, you have to keep those wings of your matrix bands back, otherwise we're going to have an insufficient isolation. But what I was going to say about the wedge was, when we're putting the wedge in place, if the little stick is in our way, then we simply twist the little stick off. But if I have a rubber dam in place, that rubber dam is going to allow me to keep the stick there. So, you know, it's a choice. And so again, etch, wash, dry adhesive, and then air. Get that micro brush all the way down to that base of the restoration, and then we'll light cure both, obviously, just for the sake of the video. I don't want you to sit through. Each quadrant, by the way, should take you about 12 minutes to do this type of work. This is all you need to do it. When Kevin was up in Winnipeg over the summer, he did some videography in the operating room, and I do have those YouTube links for you. If you DM me on Instagram, I will give you a clickable, send you a DM with a clickable link for the YouTube video, so you can see these being done, all 4 quadrants of one child, that I've done some MOs and some stainless steel crowns. So make sure that we get in as much anatomy as possible. Our interproximals, we want to keep them clean. Now you're going to see at the end of this procedure, once I've done it, I can see when I've finished that my marginal ridges are actually too high. And so you'll see me go back in with a big round burr very shortly. And some of you are going to say, well, you're in with a big round burr, aren't you taking off all of that flowable that you're placing right now? Well, I'm taking some of it away, but on the marginal ridges where I'm high, where I'm in with my big round burr, it doesn't matter if there's flowable there. Where I want the flowable to be is I want it to be in all of those nooks and crannies, in the margins and all of the grooves, so that that seals that entirely. So that's the big round burr. I don't do a ton of polishing, just enough to get some good functional anatomy there. So that's a back-to-back. Here's another tip and trick for success is you look at this radiograph, we see we've got fracture of that restoration. The reason that there's fracture, again, is not because it's not a strong material, but I didn't have enough thickness of material. And so we need to have adequate depth of our preparation in order to allow for thickness of that material. And I'm going to play you one more video shortly. I don't want to run out of time for question and answers, but I do want to show you the base layer technique. So the base layer technique is a technique where we have a base of cured flowable. So similar to the modified snowplow technique, except we have the base of cured flowable. Let me see if I can show this to you. So the base goes down there, cured flowable, and then we follow that with a layer of flowable uncured, just like in the modified snowplow, and then the layer of packable. And so that base layer technique would be for a deeper lesion. And this is actually called an open centripetal buildup technique, as opposed to the closed centripetal buildup technique, where we have the wall of the lesion built up first and then the lesion. This open sandwich technique, this open centripetal buildup technique, actually shows lower dye penetration than the centripetal closed sandwich technique. So let me show you exactly the procedure here. This is, we're going to do an MODO, so again, a back-to-back. This is our preoperative photograph and the placement of our matrix bands. So the placement of our matrix bands here, and again, the ones without the tab are in place, and I'm using my blue matrix ring, so the smallest matrix ring. And again, when we do this, once we've placed this, we need to look at the very base of that restoration, and we need to be sure that we've got some good, solid, closed margins on the base of that restoration. These matrix beams also, they're non-stick, so they will not stick to your material. So this is the base layer technique that we're going to do. So the same thing again with our acid etch, our selective acid etch. We want to get that, of course, on both of the teeth that we're going to acid etch. One of the beautiful things about doing a self-etch material is, see here at the very base, I've missed some of the acid etch, and I don't need to worry because that great universality that I have with our self-etch systems will allow the etchant to work at the base, even if I haven't quite gotten all the way down to the base. So wash and dry, and then again, microbrush right down to the base of the restoration. We're going to light cure that. This is the newest generation of light cure from SDI. This is called the Radii Expert. And here's that tip and trick. I know I've got a few people that are on here from back home that graduated from University of Manitoba like me, and if you remember, for those few that are out there with me, if you can't get any light down there, we had an instructor that used to say you can't get any gold down there. Well, if you can't get any light down there, you're not going to get any composite cured down there. So failures of the gingival box, you must be able to see and reach down to that gingival box in order to put our composite in there successfully. So I've said a few times throughout tonight already, use the proper size micro brush for that. So we have now got our adhesive in here, and we've light cured, and now we're going to put our base layer of our flowable. And I only want to have enough flowable there to go up to that gingival margin, up to that base of that gingival floor. So or that cavity floor. So we want to fill that box. Now, the success of this type of treatment is going to rely upon your flowable being highly filled. If you have a flowable material that is a poorly filled material, then you're going to have fracture. If you have a highly filled material, you're going to have less shrinkage and you're going to have success there. So once you've got a good layer at the base, then we're going to light cure again. Now, let me tell you this too. At this point where we're putting that base layer in, some of our materials, we need to allow them to settle. So we have to be sure that there is no void. And when you've got your tip of your flowable down to the base of that gingival floor, you can't lift it out without allowing it to settle. That's how you get voids. So keep the base of that tip buried in the flowable until you're full, and then you pull it back. So this material is Luna. It's a universal composite from SDI. a very nice nano hybrid material as well. We're going to fill our lesion now. So if you can see here, so this is the packable going in, but we have that really nice base of our flowable in the first primary molar. And then we're going to fill now with our packable material. Light cure again, and then I do prefer to put a top coat on there, and then we're going to be finished that restoration. One more tip for you for success. Oh, sorry, I gave you that one already. I guess it's worth saying twice. Proper isolation and matrix placement, and if you can't get the light down there, then you can't see. I want to show you one more unique material here in an MODO, actually an MOL and a DO, and an acid etch. And I'm going to use a material called Activa. This is actually Activa Kids. It's a bioactive ionic resin. And this particular material, if we're going to be using this, if any of you have used it, it's a very flowable material. It's almost like a very thick flowable that we're placing as a full restorative. It's got great properties and great bioactivity. But if you're going to be using a material like this, you absolutely must have a matrix system in place, because this material is not packable at all. And so if you have any hope for having any type of proper embrasure, any type of proper contact or proper anatomy of that embrasure, you absolutely must use a matrix system in order to get this in there properly. So this MODO, this is the Activa Kids going in place. And again, we don't want to have any voids. So the tip of that Activa needs to be buried down to the gingival floor, and it's almost like you're backfilling. It's a lovely material, and we obviously will light cure this one. Another great light cure out there from Velo, and this is an immediate post-op with that Activa Kids. And here's another one, tips and tricks for success: recurrent or residual decay. There's lots of talk about, you're okay if you do some selective caries removal as long as you have an absolute seal. Well, absolute seals are absolutely really hard to get when you're using composite. And so we want to have as much decay removed as possible when we're using a composite restoration. And let me show you just one more clinical case before we open it up to questions and answers. Tips and tricks for success using the LM dark diamonds that you saw in one of the videos that I already showed you. I'm going to show you this case with Evan S., which is Clinical Research Dental, Clinician's Choice. And so these are my dark diamonds of choice. I generally use 3 of them. This is an anatomical shape. You can't quite see because it's kind of buried in the composite. So we're going to get that in place, followed with our ball burnisher for that Evan S. So we're going to, again, shape it as much as we can, get away excess as much as we can. And we are going to then do our embrasure as effectively as we can. So again, here, this all relies upon having good matrix in place so that we have something to lean our instruments against and guide us. Now, as we said at the outset, I had Kevin from Garrison Dental Systems come down to Dental Solutions, pardon me, come down to Winnipeg, up to Winnipeg last summer. So I do have several live pedodontic cases that he filmed. I was going to show you some videos, but you can see them online on YouTube instead. And I do talk through them on YouTube, so you can see them there. And I just wanted to point out, because what's not on that YouTube site with these videos are the post-ops of that child. And this is a 6-month post-op of that child, all 4 quadrants, where we've done some stainless steel crowns, but our MOs, and this is omnichroma that we have used on that child. So omnichroma on all of the MOs on his 2nd primary molars, and also on several of his cuspids on the distal. So I just wanted to point out that we have some nice longer term results as well. Also on that YouTube link are pedodontic techniques. So I will talk about how to get on a rubber dam, why we need to isolate, how to get the rubber dam on, and to get the matrix system in place as well. And then I'd show also, this is a case where I go through putting just some materials onto the typodont so that we could talk it through a little bit more. So these are the YouTube video links, but as I said, if you DM me on Instagram at Kids Dentist Carla, I will send you some clickable links as well. So I believe at this point, I should probably show you the end slide. If I'm wrong, Kevin, you better tell me now.
No, that's perfect. Yeah, we just want to make sure you've got that code. Write that code down quickly. And then if Dr. Carla, if you're ready, we can start going through some of the questions. We've got quite a few of them here.
Go for it. Only ask me the ones that I know the answers to, okay?
Oh, okay, well,
okay.
I'll see what I can do. Let's see here. Let's see. Do you ever use Sonic Fill?
You know what? That's one material I have not trialed yet. But I do routinely use a caps warmer when I'm placing my materials now. So no, haven't used Sonic Fill. Don't have anything against it. Would love to try it. Haven't used it yet.
Okay, that was another one of the questions, was a composite warmer. So I guess we answered that one. So
yes, so I do use a caps warmer very routinely now for the last few years. It was one of those things that I didn't realize I needed until I had it, and now I can't seem to live without it.
Now, are you warming just the composite, or do you place the instruments in there as well, or?
I'm just warming the composite. There is place in there to place the instruments, but I find that the composite, once the composite is warm, I don't need to have the instruments placed. Certainly not for these types of procedures that are very quick.
Do you use anesthesia on the palate when you're putting for placing the rubber dam?
I use a topical anesthesia on the palate for the rubber dam. I don't generally use an injection of anesthesia on the palatal, not for routine rubber dam. The topical anesthetic I use is a compounded topical anesthetic, and it's quite strong. If you put it on there and you leave it on there, and then if you put your rubber dam on and you place it on slowly enough, then it's not going to be uncomfortable for the patient. If you snap it on, then that hurts.
Okay. Yeah, I remembered you were saying that you had a local pharmacy put that together for you.
Yeah, and I believe in the States you can probably also get that. There are places that you can get it compounded that are sold commercially. I don't know where in the States, but I know that people do get them.
Okay. Here's a good question. If you're working restoring an adult molar adjacent to a primary molar and both need class 2, which ring would you potentially use?
So I need to use the ring that's going to stay on there. The one that I use most commonly for primary molars is the blue ring. But if I can get and then I'm not so worried about the height, because my height I can also adjust with a different matrix beam. So the blue one would be my go-to. I'll use my orange one if I've got an adjacent primary tooth. I'll use my orange one if my blue ones are all in the sterilizer.
Okay. Any difference really in using a sealant versus a flowable when you're capping off the restorations?
Yes, there is a difference. So the sealant materials in general tend to be of a lower fill content than flowables do. And so because of that, they don't wear as well. So if I'm doing that on the occlusal of a restored tooth, I need to have better wear. rather than the sealant that might be more flowable. So I go for a flowable material instead of a sealant material almost always.
Okay. So, two questions about the burrs that you were using. What burr was it that you used? Was that a 556?
Yeah, so it's a carbide 556 that I use routinely for my my MODOs, and sometimes I'll go in with an 1169, so or a 169, a tapered Fisher burr.
Okay, that was actually the next question. They were wondering
Okay,
what that one was after that. So,
there you go.
all right. Let's see here. Lots of questions here. Scrolling down through. Composite warmer. Do you ever use isolite versus rubber dam?
Yeah, so I've used Isolite. I think it's called Xeris now, and I use Dry Shield, and I do speak on behalf of Dry Shield on occasion as well. And I do like the isolation systems. They are fantastic for a lot of things, and for speed, and for avoiding having to put a clamp onto the tooth, because sometimes that is a concern to the patient. What they don't do though is they don't allow me to move my handpiece in certain ways because they're bulky. So the isolation systems don't let me tip my handpiece as much as I would with or would want to with a rubber dam. So doing restorative, I do prefer to use a rubber dam. Doing sealants, cutting crowns, a number of other things. The Isolite Xeris Dry Shield are excellent for. I wonder too if the future of our practices with COVID-19 might change the way they look in the way we're isolating, and maybe using some combination of the two in the future. But that's just a speculation and aside. So yes, I
Yeah.
do love using them, and I wouldn't want to work in my practice without an isolation system as well.
Okay. Now, a question about when you're doing the modified snowplow technique, you've got the flowable at the bottom, and then you're coming over top with a higher density material. Are you ever worried about the flowable not curing properly because of the different densities?
Right. So the flowable at the base is such a thin layer that's down there, and if you're concerned about the depth, because we have so many very excellent bulk fill materials that will cure through 4 millimeters, some of them 5 millimeters, and some of them 6 millimeters. If we have a lesion that is deeper than that, then you do the base layer technique. And then you have a layer that if you're concerned about it not reaching through, but the way our bulk fills are now, and the translucency and the transmittability, if that's a word, of light through them to reach the base, I'm not concerned about it not curing in the depth of these lesions. Remember too, these primary teeth, they're not very deep. They're probably 4 to 5 millimeters at the very deepest anyway.
Okay. Now, good question here. Do you still need a wedge if you feel that you've got a good seal at the gingival floor?
You still need a wedge. You still need a wedge. You absolutely need a wedge, because the matrix system, the ring is pulling back my band, so that's making it tight, but I would not want to do it without a wedge. Just in any given time, if you put it in place with the ring, you'll see seepage through, and that wedge is preventing the seepage through of any curvicular fluid. So I always put a wedge in.
Let's see here. Best way to avoid bleeding at the gingival floor to prevent
Yep.
nicking it with the burr, I guess, when you're prepping is what the concern was.
Yeah, even if you do, I mean, very rarely, you saw in those videos too, that as I was putting in the matrix system, you could see some bleeding, right? But once our matrix system is in place and we've got a thick enough wedge, because that's another point too, right? That I didn't touch on. Choose your wedge to be the right thickness, and the wedges come in, extra small, medium, large. So we want a thick enough wedge to be able to help to seal that gingival floor margin.
Do you do a pulpotomy on every tooth where you see the pulp? If not, what do you use for pulp capping?
Okay. So do I do it on every single tooth? No. And you were talking primary teeth. So I don't know whether the question was about primary teeth, but let's talk about primary teeth. So it depends. It depends on how long that tooth needs to stay in that child's mouth. It depends if the tooth was symptomatic. It depends if it was a mechanical exposure or a caries exposure. So cases where I would do a pulp cap on a tooth would be in cases of a mechanical exposure on an asymptomatic tooth where the tooth doesn't need to hang out in that kid's mouth for too many years. And materials of choice for doing a pulp cap would be something like the TheraCal LC or some of our MTAs like Neo MTA or Biodentine. All of those are good pulp capping materials. As our materials evolve, they get better and the ability of them to seal gets better. And so our pulp cap successes get better. But years ago, when we didn't have the MTAs and the TheraCal LC and the TheraCal PT and all the rest of our newer materials that we're using in pediatric dentistry, and I know MTA has been around for a long time, but not so much in pediatric dentistry, the failure rate of pulp caps of direct pulp caps was quite high. And only in recent years, has it become more successful as our materials become successful. So it depends on a lot of things. So that's not really a complete answer for you, but in the constraints of this time, that's what you get.
Complicated question, yeah. Complicated question.
Yeah.
A couple questions about the Activa relating to etching and bonding. Are you still going to do your full etch and bond with the Activa product? Yeah, okay.
Yeah, 100%. So, and this is something that initially when Activa came out, Activa does have an ability to bond to tooth structure, but I do etch and bond them in place when I use my Activa for retention.
Quick answer here for a couple of the people. If you go out to YouTube and you search Garrison Dental channel, you'll be able to find those links for Dr. Carla's videos as well. Good question here. I'm curious about this. SDF prior to restorative treatment. Do you ever use any SDF in your practice?
Absolutely. So, I'm kind of glad you asked because it's quite timely. So I do use SDF.
I've seen a lot of stuff on it lately, and this question is here, and I'm like, I want to know the answer to that one.
I do use it. It's an excellent material, particularly now with COVID-19 and trying to be minimally invasive. I think that it's a material that we're going to be using more and more. I've done a series of webinars for SDI at their request on their Revastar, which is their silver diamine fluoride potassium iodide combination. So it's silver diamine fluoride and then potassium iodide, which minimizes the staining. To make a very long story short, what you should do, tomorrow I'm giving a webinar for SDI specifically on use of Revastar, silver diamine fluoride, and then restoration with glass ionomer. It's called minimally invasive dentistry. Now you need to find it. So if you want to find it,
as you say, everybody's going to want to see that.
I don't have the link to show you right now, but I do have the link. So I will post it on my Instagram at Kids Dentist Carla, and you can go there to get the link. So I'm giving this tomorrow at 11 a.m. Central Time, and I do know that they will also record it, so you can go on there and you can get. I don't have it up there on my Instagram this second, but after we get off this webinar, I will put it up there.
Okay, I think we're a fraction of the way through the questions here, but kind of running out of time. Several questions about recording and slides. I'll be sending out a link to the recording tomorrow once we get it taken care of and posted up on YouTube. So we'll send that out. And shortly, maybe about 15-20 minutes from now, I'll send out the evaluation and quiz. You need that WB420C code. Fill out your quiz and send it in, and the system should send you the CE certificate right away. So Dr. Carla, hey, thank you so much. What a great webinar this evening, and a lot of great interest here. So really appreciate your time.
Thank you. I so appreciate having the opportunity to be there. As I said at the outset, it's phenomenal, the opportunity to speak to so many people. And, I hope you're all social distancing and you're not close to each other on the computer. I know you're far enough away from me. In all sincerity, I wish everybody, health and take care and wash your hands. And we will get back to normal dentistry. It'll be a little bit of a new normal. I'm not sure exactly how it'll all look, but we will get there at some point. And in the meantime, stay safe and go give your kids and your spouses and your parents a kiss.
All right. Well, thank you, Dr. Carla. Good night, everybody.
Good night.